All right, hey guys, happy 2025. It's the first live that we go after the new year, so I'm excited for that. That's our case that we've done. I think that was the last case we've done in December, and we're gonna talk about what we've done. She's less than a month out. She's doing amazing, and we're gonna go through the process, kind of how she was and how she's gonna look. I'm gonna write here to write your questions below. And we're gonna answer a lot of questions that we've been getting about lipedema. And then the common questions we've been getting is, do I need a formal diagnosis? Can I come off hormonal replacement therapy? Can I come off GLP-1 agonists like Ozempic, Mounjaro, all the other medications? What type of compression do I need? What's the pressure? How long do I have to wear them? What happens to the skin after LippyLipo? What happens if that's not after surgery? Like, what do I need to do for that? Massage it, all the other stuff. What's the BMI limit? Is there any specific limitation what I need to get to get the procedure done? So we're gonna answer all these questions. We're gonna talk also about how we were able to take our patients here who's stage 1, type 4 to this case who looks amazing, and what's the difference between the different stages and all the stuff that we need to do. So gonna get started here. First let me kind of talk a little bit about our patient here. She's 55, came to us stage 1. She has a long history. She had a lap band at some point that was taken out 10 years later. She lost some weight but couldn't lose the lipedema fat. Then she went on to GLP-1 agonist. She also lost 20 pounds being on that as well. And no matter what she did, she was able to lose the regular fat, but she was never able to lose her lipedema fat. And as you can see here, typical lipedema presentation, you can see some of the weight loss she had from the extra skin. She lost, again, like around 20 pounds being on GLP-1 agonist. But you see typical ankle of lipedema ankle. Kind of like it goes straight down. You don't have the shape of the ankle. As you can see, you see the kind of the cuff that she has here over the ankle. And most patients with lipedema, when you look close, they have like 2 creases over the ankle area. So if you look at the ankle from the front, most people have 2 creases, and that's where kind of the cuffing is, or where that lipedema fat is sitting. And she's starting to have that. You see, like she has 1 crease here and another crease there. Same here, 1 here and 1 there. Sometimes it's tough to see it for somebody who's not like used to it, but immediately we can see that. So again, she was able to lose the weight, but not the lipedema fat cells. You can see she has a lipedema nodule here, another here, weight loss here. You see kind of those irregularities that look like cellulite, and most patients misdiagnose them. They think they have cellulite in their legs, but actually what they have is lipedema. So anyhow, came to us, 55. We did her case on December 17. We did 360 lower legs, kind of the lower, and kind of did that lower part. And then 2 days later, we did her thighs. And you see kind of this is the quad muscles. You see kind of beautiful transition to the knees, inner knee, outer knee, and kind of on both sides. These are the dots where we kind of go in to access to do the liposuction on her. So that's kind of like that's how she is. Did great in both procedures, walked out, big smile on her face, and that's the beauty about LippyLipo. Done fully awake, no general anesthesia, no sedation, no PO anesthesia. Nothing. Patients take like Tylenol and Advil or ibuprofen, and that's about it. Now, to go back to the main questions we've been getting over the holidays, and I try to save as many as we can so we can go over those on the lives here. So one of the common question is, do we need to get formal diagnosis before coming for the procedure with us for LippyLipo? And the answer is no. You don't need any formal diagnosis. Most of the formal diagnoses are used for patients who go under insurance. They have to go through the entire process of like 6 months documenting this and that. But in our practice, we don't do insurance, so basically you don't need a formal diagnosis. Most of our patients, they get their consultation virtual. They kind of basically do all that consultation, all the paperwork virtual, and then they come to us just for the procedure itself. And the procedure is, we do 1 procedure a day. That's all what I do. We only see 1 patient the entire day. So you'll be here, just you. which kind of like odd for most patients because they're used for the busy waiting room. We just don't have that. It's just the patient, their significant other, and that's it. We do the markings, we do the ultrasound, measurements, then we go to the operating room, patient's fully awake, we get to talk, chit chat, we do the entire case. And then we're done. I'll kind of walk the patient out. She goes to her, to the hotel. Most patients, if they have a hemoglobin above 14, we're doing two of their procedures the same week. So we do one on Tuesday, one on Thursday. Most of the time. Sometimes we do Monday, Wednesday, and kind of like we have some exceptions for certain people where we're kind of adding them to the schedule if they need like an opening. Because we've run through issues where some patients where like they're about to get menopause or about want to get pregnant and want to treat it before pregnancy. So we've been like very open with the schedule as much as we can to be able to get those specific patients where time is crucial for them. So anyhow, so we did her on Tuesday, then the second case was done on Thursday, did awesome. And that's most patients, they need two procedures, lower and upper. That being said, patients who have stage 3 or 4, like really advanced stages, then we can't do the entire full lower extremities in 2 days because you hit the limit of the 5 liters. Then on those cases, we're doing 3, sometimes 4, if they have like, let's say 20 liters of lipedema fat, then you're talking about like 4 procedures or 4 sessions. But I would say 80% plus, we're able to do them in 2 sessions. So let's get some of the questions here and then we'll go down. One question is in Spanish. Let's see if I can translate. I couldn't understand your question. Melia, if you want to type it in English, I'll answer it. Sona is saying, I hope to make that. Absolutely. One question about the price. For pricing, guys, go to our bio, kind of submit your information, and then depending on the info you send, then Jerry will get back to you with a quote on that. All right, so first answer about do I need a formal diagnosis? You don't need a formal diagnosis. And really, it's a waste of time, waste of energy, waste of money to go through all this stuff. Really, if you go over the live that we've done, the Q&A live, Lipedema live that we've done, you'll be able to answer, you'll be able to diagnose yourself. Because lipedema, it's a clinical diagnosis. Once you look at the legs, even stage 1, when you look at it, you'll be able to tell. And if you couldn't tell by the pictures, the things that you look at, like this patient, most patients kind of very similar. It's like heaviness, swelling, easy bruising. They have the shape, that shape and that fat cannot be lost with diet and exercise. And that's kind of like common across most lipedema patients. Now you want to advance it, people can have hypermobile joint, autoimmune diseases, lupus is common, the Danlos syndrome is common with lipedema patients. So kind of really dig deep into it. And that's kind of, so if you go over all the lives Q&A that we've done, you're going to be able to tell. And if you're not sure, we're happy to help you. Go send us your info, and then we'll get to you on that. Okay, Melia is asking what happens with the skin that is between the legs, the loose skin. That's a great question, and that's one of the common questions we're going to address. Is, as you can see here, our patient lost 20 pounds being on GLP-1 agonist, which is like Ozempic, Mounjaro, all the new generation weight loss medications. And you can see already she started having loose skin on her inner thighs. So I tell patients it's a bell-shaped curve, right? If patients are stage 1 and 2 and they're like 20s and 30s, no history of massive weight loss, they don't need anything. That skin's gonna do great. Totally on the other end of the spectrum, patients who are stage 4, they lost 100 pounds. These patients need thigh lift with or without LippyLipo. Kind of like, and then you're gonna have the people in between, like our patient here. So let's say like our patient here in her case. So when I look on the table, she looks great. Now that being said, she's laying down, and when you lay down, the skin relieves very well. When you lay down, you don't see the outcome from the skin, but you see the outcome from the liposuction. So I know from a liposuction standpoint, she has an amazing result, right? Now the question, what's gonna happen to the skin? My prediction is her skin from the knees all the way down, it's gonna do amazingly well. From the knees up, it's gonna depend. She's 55, she's in between. She had a lap band many years ago. Then she's on GLP-1 agonist. So it tells me she's gonna be kind of more in the middle, more towards potentially needing skin resection. Sorry, I'm losing my voice for you guys. But the skin on her, my prediction about a year, if she's gonna need something, it's gonna be basically to that inner thigh area, just because of her massive weight loss, or her weight loss with the band and the GLP-1 agonist. You can see also that she was starting to have kind of when she stands, because it's a cylinder. What happens is the skin is gonna want to move south towards the knee area. So, but wait a year before you do anything to the skin, because you'll be surprised how much the skin redrapes well. Again, my experience has been knees down, even for later stages, patients do very well. Nothing needs to be done. Knees up, depending on age of the patient, collagen, health, lifestyle, smoker, non-smoker, lipedema, it's a collagen problem, so it tends to kind of affect the collagen, so it puts people even at a disadvantage. If they have EDS with it, then it puts them at a high risk of not being able to redrape. Our patients here, I'll have to say, if now she wants to be like so tight, she's gonna need skin resection. But if she's okay with a little bit of laxity on that upper inner thigh, which she already has at this point, then probably she doesn't need anything. But that's a common question we get asked about skin. So if you're at home and you're not sure, let's say you're like 65 years old and you're stage 3 and you had a history of like 20, 40, 50 pounds weight loss, almost 80% you're gonna need some sort of skin resection a year down the line after you've done with LippyLipo. But if you're like in your 30s, relatively healthy, you're stage 1, you're gonna be good. And you're gonna have the people kind of in between. It depends on kind of where they're standing, what's their stage, age, collagen status, how much fat we took out, and kind of like how much we're able to kind of like remove out. Because the other thing that kind of factors in here, and we do that on every patient the morning of the procedure, is I do an ultrasound. And the ultrasound, what I love about it, and for the patients, it shows us exactly the thickness of the lipedema fat. Because we know lipedema fat sits in one plane. It sits in the plane that's between the skin and the muscle, right? That's anything between the muscle and the skin, it's made of regular fat and lipedema fat, but nothing else. So you have like some fibers and all that stuff. But so if the thickness is that much, even though when we take, and we do that as well, we take the measurements, 360-degree measurements, okay? We get kind of all the measurement. So you can have a patient, let's say measurement 50, both patients are measurement 50, but we do the ultrasound, and these patients, some patients might have that much thickness, and the other patient might have this much thickness, even though the measurement is the same. Why is that? Because the change is in the bone and the muscle. So if somebody has underlying bigger muscle mass or bigger bone density and bone mass, then they're gonna have less lipedema fat for the same circumference. So that's important. So these people who have higher bone mass, higher density mass, actually their skin is gonna degrade better for the patients who don't have that at the same 50 circumference. So that also factors in. And when we're doing the ultrasound on the morning, we're able to tell kind of like, okay, well, we have a lot of lipedema fat, so we know we're going to have to do a lot to take most of that out. And when you take most of that out, where does the skin going to go? Knees down tend to do well, knees up, depending, weight loss, collagen, all that stuff. And then and that's how we pretty much can relatively predict, like 70-80% prediction on how the skin is going to do. But irrespective, you want to give it 1 year before you do anything to the skin, because you'll be surprised how much redraping happens over that year. And if somebody is working out and exercising, you're increasing your muscle mass. When you increase your muscle mass, you're gonna need less skin resection, so better skin redraping. Okay. Alina is asking, how long is the recovery before you can fly back home? Great question. Most of our patients, we tell them 2 days, unless they're flying from overseas. Cross-Atlantic, 3 days they stay. People within the US, 2 days. Canada, same 2 days. Sometimes we tell them 3 days, depending on the airline. Certain airlines, if there's anything, because we will get drainage after the procedure from the fluid coming out. We've had one patient at 2 days, like the Canadian Airlines, like, oh, but 2 to 3 days, depending on where you're coming from. Within the US, 2 days, outside the US, 3 days. KB is asking how much is LippyLipo on 2 legs if insurance doesn't cover, and how long must one stay before flying home? We just answered the flying home. In terms of cost, it really varies from one patient to the other. If you go to Bio and submit your information, Jerry can get you back with a quote on that. I see a lot of familiar names here and faces. Some of them are our previous awesome patients. Heidi is asking, will you operate on someone with heterozygous factor V Leiden gene? Good question. So we explain about, let me talk a little bit about what factor V is. So factor V, it's a genetic, basically it's a gene that predisposes somebody to blood clots, okay? So you can have homozygous, basically you're having two genes from the mom and the dad, or you can have heterozygous, so you can have one from, let's say, one of the parent and the other is normal. So heterozygous is better than homozygous because homozygous higher chances of developing blood clots, heterozygous less chances of developing blood clots. In our cases, we do them fully awake. So when the case is done fully awake, the risk of blood clots significantly go down. So if you have any homozygous, heterozygous, all that stuff, you want to go down the route of awake because you drop your percentage of developing blood clots significantly. Because when you're awake, you're moving, you're as if you're sleeping, right? Or you kind of wake up, you move around. It's even better because you're moving around, you're doing the stuff. That being said, it's still surgery. It puts you at a higher risk than, let's say, not doing anything, that's being at home. But let's say awake risk of blood clots, let's say it's here, sleep risk of blood clots is here. High volume blood clots in sleep puts you kind of like that much. So definitely you want to go the awake route. Now that being said, we're very selective on whom we choose on as patients because we want to have the best outcome possible, the safest way possible. The heterozygous, most of the times we get hematology clearance, kind of take a look at that, see if they have any history of any risk of DVT, PE in the past, family history, all that stuff. So it makes it a little bit more challenging than a typical person who doesn't have it. But it's not like we say no from the get-go, we kind of look at it deeper. If somebody had histories of like DVTs, PEs, multiple miscarriages, all that stuff, then that puts them at a higher risk. It's better to be done in a hospital setting. But for somebody who doesn't have those, and they have hematology clearance, it makes it, it's more favorable prognosis on them. Janine is saying, that's me, but I can live with loose skin. And that's a great point, Janine. So basically, and from a skin standpoint, and it's important to talk about skin, but also it's important to talk about lipedema and the functional aspect of it, which is pain, discomfort, easy bruising, heaviness, affecting lifestyle, not be able to walk, not to be able to play with your friends, with your kids, with your grandkids, to hike, to do all the fun stuff that you normally do. So most people, and most of our patients are like Janine here, they're like, I don't care. Like, I just want to feel healthy. I want to feel better. I want to be myself. I want to be able to enjoy the stuff that I want to do. So even if I have a little bit of skin, it's not a big deal. I'll probably never have a thigh lift done. And when we look at our patients, and that's all what we do in our practice, all what we do is lipedema and LippyLipo. We don't do anything else, even though we get so many calls about it. When you look at our patients, very, very, very minimal percentage, I would say less than 5% end up getting thigh lift because they just don't care about the skin. But for some people who do, they fall within that 5%, and that's okay. Then you gotta do it so you feel better, because that's why you had that procedure done anyway, is to feel better and feel good about yourself. But and that's what I love doing those lives, is it gives you an idea, right? I mean, let's say that patient has lost 100 pounds and she's already starting with the skin hanging here and there and a lot of loose skin. You know she needs a thigh lift even before getting rid of her lipedema. And now another important point that unfortunately I've seen some patients go through is they get a thigh lift before they treat their lipedema. Never ever do that. And the reason for that is if you get skin tightening and then you come to us for the thigh lift and then you come to us for your LippyLipo, we're gonna treat all that lipedema fat. Right? So you're going to take that lipedema fat out, then what's going to happen, then you're going to need another thigh lift. It's because you're going to need probably, because you already had skin that was not really draping well with your massive weight loss. Now you created another problem, which is another skin resection and another thigh lift. So always treat your lipedema fat first and then do your skin resection, not the other way around. That being said, some people unfortunately didn't know, or they went to a surgeon who didn't know about lipedema, or it happened many years ago where they didn't know much about lipedema. Unfortunately, they had a thigh lift done. And in these cases, it is what it is. We just tell them, hey, we're gonna do a LippyLipo, we're gonna give you an amazing result, you're gonna look great, but you might need skin resection, because especially if they have 10, 15, 20 liters of lipedema fat, even after the thigh lift, then you're gonna need another skin resection for that. So, but that's a minority of patients. So we're trying to prevent future patients from doing those unfortunate positions where certain patients are in, so that they don't get their thigh lift done before. So if you're entertaining getting thigh lift and you have lipedema, don't do your thigh lift. Do your lipedema first, and then do your thigh lift afterwards. All right, Sarah is asking, how would I know if I have lipedema? So you have lipedema as a clinical diagnosis. So you have certain symptoms and you have the signs, the looks. So the looks are tree-trunk appearance, cut-off sign at the ankle. Not everyone has it, but most common type, which is type 3, patients have the cut-off sign at the ankle here. And then you have the symptoms of lipedema, which is easy bruising, swelling, heaviness, pain. Somebody's touching the thighs, just pain. The fat is resistant to diet and exercise. It runs in families. These are all signs of lipedema. If you go, Sarah, if you go to our live Q&A, we spend significant time talking about how to know if you have it. You see multiple pictures, and then once you do like few of those, you'll have a better idea of kind of like, what's that. And also if you go on our website, go salamehplasticsurgery.com, go to our blogs, and then we have our own patients where we have like stage 1, stage 2, stage 3, stage 4. Then when you get to see, you'll be able to tell kind of like which one is stage what, and you'll be able to diagnose yourself what stage you are and what type you are. And I feel when we've had that blog, when we put our patients' stages instead of just cartoons, we've had so many people reaching out to us, thanking us for that, because it's very hard for the patient to kind of like look at the cartoon picture and then say, okay, this is stage 1 or 2. But when they see other patients, they say, these are my legs. So they're able to connect on what their legs look like and what the other person's legs look like. And if the other person's leg is exactly the same that their leg, they're able to immediately kind of like match those. So like, these are my legs, okay, this is stage 2 or 3, then that means I'm that stage. And then they see, okay, well, I have it in my arms, now I'm type 4 and all that. And we talk about all that stuff in there. Many are saying, thank you for the explanation. You're welcome. J-Pen is saying, do you take people with diabetes? Absolutely. Common question, diabetes, no problem. We've got to make sure that the HbA1c is under control, not like somebody's not like an active diabetic high, but regular diabetes on diabetic medication, no problem at all. It doesn't affect much of lipedema and with LippyLipo. So if somebody is diabetic or high blood pressure or all of the other regular medical problems, it doesn't affect us. Again, it's an awake procedure. It's extremely safe, and there's no general anesthesia, and it's just like, it really takes all that side effects or complications that comes from general anesthesia, all the other stuff. And there's no like, it's not a thigh lift, it's not a tummy tuck, there's no of these long incisions, tiny little dots to go in and extract the fat. There's no manual extraction, none of that. Just like tiny, simple, little, easy, like very, very delicate kind of the procedure. It takes time. It's a lot of energy. It's a lot of work to be done to get us to this, to get us here. But it's not like, it's not general. It's not a huge cut. So diabetic, all this stuff, it doesn't matter. And that takes us to the other question we get is, do you have a BMI limit? And the answer is no, we don't. And most people are like, oh, you don't? It's like, we don't, because it's awake. Whenever you go into putting somebody to sleep, then you start having all these requirements, because now you're taking over their lungs, you're taking over their movements, you're taking over their brain. It's just now the risk of that procedure significantly goes up. But when you're fully awake without sedation, it's like you're awake. it's like relaxing at home, or it's like just laying down or getting some teeth work or kind of other stuff. So it takes that. So from a BMI standpoint, since we moved to awake, really not much limitation. Now under the general anesthesia, you gotta have a BMI, because let's say you want somebody to turn on their stomach. If they're totally paralyzed or they're under general anesthesia, you gotta worry about their position, nerve injury, brachial plexus injury, all that stuff. So you really want to have it cut off. Some people have BMI 35, some people can go to 38, so 42, depending. With us, you're awake. If you can walk here, you can do regular daily stuff at home. It's not, we don't look at it. We look at BMI more of kind of like, it gives us an idea of how many procedures they're gonna need or how many sessions they're gonna need. Somebody who has a BMI of 22 is gonna need 2 sessions to the lower extremity. Somebody who has a BMI of 42, they might need 3 sessions, maybe 4, depending on the ultrasound that morning and the thickness from the skin down to the muscle. So that's kind of like how we look at BMI in our practice. Not to tell patients you're not a candidate. We look at BMI just to give us a better idea and a better understanding of how many sessions does that patient need. Because the patients, they want to plan their lifestyle, they want to plan, because most of our patients, they fly here. We're located 1 hour north of Nashville Airport, so they fly to Nashville, like 1 hour here. So they wanna plan their kind of like things around their life. If they need 4 sessions, then that means they need to come twice. If they have, because the most we can do is 2 a week, right, for that patient. But if they need only 2 sessions, that means they only need to come once. So then they need to plan their lifestyle, and they need to plan their finances, all that stuff. So we kind of able to help them in that aspect. Okay. Ayori is asking, do you suggest trying a GLP before surgery? That's a great question. I think our patient here is on GLP-1 agonist, and she lost 20 pounds. And to answer the first part, patients who are on GLP-1 agonist or Ozempic or Mounjaro or any of the new generation medication for weight loss, we used to take them off those medications, but recently we keep everybody on their medications because we've noticed it doesn't make a difference, and I want to keep patients kind of so that they don't have variation. So if you're on HRT and hormones and all that stuff, stay on it. If you're on GLP-1, stay on it. Don't come off of it. Stay on it, continue your weight loss, get where you need to get, and then you continue that afterwards, and stay on it afterwards as well. So the short answer is we don't take patients off it. Now, do we recommend it? It's very hard to kind of go 100% yes or 100% no, because we really don't know the long-term effect of GLP-1 agonists. And I'm very kind of cautious when I say yes, definitely go on it, because we really don't know the long term. But what I can say is patients who are on GLP-1 agonists, they are losing the regular fat. They're not losing the lipedema fat, but it's minimizing the amount of session that they need on their lipedema surgery. So you need less LippyLipo sessions if you're on GLP-1 agonists, because you're dropping your regular fat. So we don't have to spend time removing regular, because when you do liposuction, you're taking out both regular and lipedema fat. So let's say stage 1 or 2 patients, probably not much difference because you're gonna need 2 sessions anyway. But stage 4 patients, if you're on GLP-1 agonists and you drop like 50 pounds, right? So you probably saved yourself a session or 2 on the LippyLipo side. So that's how I look at it. So if you're on it and if you're losing, great, I would just stay on it. Sarah is asking, how can I know if I have lipedema? If you go to our live Q&A, really we talk significantly about what's LippyLipo, what's lipedema, how is it treated, what stages of lipedema, what's the types of lipedema. But quick answer here is typical symptoms are easy bruising, swelling, heaviness, it looks like cellulite, resistant to diet and exercise, it runs in family, the tree-trunk appearance of the legs. These are common symptoms, signs and symptoms you see. Missy is asking, do you do diagnostic exam via telehealth appointment? I live in Texas. Most of our consultations are done virtual, and the way it works is you go to our link in bio. We don't do diagnosis in our practice. We don't need diagnosis for our patients. We do consultations for the LippyLipo. So when basically most of our patients come to us, they come for the consultations basically so that they set themselves up for liposuction, basically for LippyLipo. So we don't do consults to diagnose patients because we don't need diagnosis with us. No need. Goli is asking, are you doing legs lift surgery after lipo? We don't. Our practice, we only do LippyLipo. That's all what we do. And we only do one procedure per day. So we don't do thigh lifts, we don't do tummy tucks, we don't do breast reduction, we don't do any type of anything other than LippyLipo, we just don't do. And the reason for that is, even with that, our schedule is fully booked. So it's time, and it's time and kind of like, what can we do? How can we position our time where we can help as many lipedema patients as possible, and with the least risk as possible? And part of the reason is, when you go into thigh lifts and other stuff and you start making all these long incisions and stuff, your risk of complications significantly goes up compared to just liposuction. And when the risk of complications significantly goes up, you don't want to be where your surgeon is like 5 hours away or 3 hours by plane, or on the halfway through the country, because it can be a simple problem like skin separation or stitch trying to come up, or a small wound infection or something that's so easy to treat if you're like next door, right? So it's just, I tell people, if you're ever gonna need that a year down the line, do it with the best person that you can find locally within your area. Don't fly overseas, don't go that for these like major procedures. LippyLipo, liposuction, yes, very low risk. But the others, it's not worth it. It's such a headache on the patient. They have to find, and then the new office, they're like, oh my God, and it's just, it makes it so hard. So, and that's additional reason why we don't do it. But really, the main reason is my passion is LippyLipo. That's all what we do. That's all what we're focused on. And I'm the type where I just love to do just one thing, be the best in the world at it, and that's it. I don't want to do anything else. I just want to I want my patients to come here, get the best outcome possible, the best experience possible. And I'm so specific and detail-oriented that literally we spend the entire day just on one procedure, which is crazy. No one ever does that in medicine, like just all day just to do one thing. But that's my personality, and that's the patients that we get are patients who they're looking for high quality outcome, high quality experience. They want the best possible outcome to get with the least risk possible. They want consistency in results, and that's basically a match between us and our patients. You won't see us doing insurance cases. You won't see us doing multiple cases a day. You won't see us doing multiple numbers, and it's just not us. Goli is saying, I meant remove of lost skin. We talked about that. I'm gonna save this live, Goli, if you wanna go back to it, and then if you missed that part, go ahead and watch it. We talked about loose skin, how do you know if you're gonna have it or not, and what to do about it. But let's keep on going so we answer other questions here. Aldous is saying, how long have you been doing this job? So a little bit about me. I've done general surgery first at Yale. I did 6 years over there, and then I did 3 years of plastic surgery at Vanderbilt, and then opened the practice here in Bowling Green, Kentucky, which is an hour north of Nashville, in 2016. But when I started on the general surgery practice, that was in 2007, kind of and then prior to that, 4 years of medical school, 2003. So I would say 20 plus years in medicine, and in the practice here, 2016 till now, so about 9 years. And we've done thousands and thousands of these surgeries, and now that's all what we do as LippyLipo. Sarah is asking, if I lost weight and have lipedema, can I remove the excess skin and treat the lipedema on the same surgery? Good question. I wouldn't recommend that. You can, and I've certainly done it in our practice, especially when we were doing cases on general anesthesia. Almost always I regretted that because it's too much surgery, too much risk on the patients, too much work on the surgeon. You can do it. You get like a relatively good result. But if you want the best outcome possible with the least risk possible, I would do your LippyLipo first, get an amazing outcome on LippyLipo, get amazing experience, get rid of your lipedema fat, wait 1 year, let your skin redrape, and then do skin resection. So the short answer, if that was my wife or a family member asking that, I'm like, my advice would be don't. Do LippyLipo, do this, finish that, and then a year later do that. That being said, I understand why people want to do it at once. Because it's like one surgery, one recovery, get done with it, potentially cost can factor in, and even though it sounds like amazing on paper, it's just most people like end up higher complication risk, higher risk, they end up that, and then they're not happy about certain things, they need another revision and another thing, and here and that. So most of these people end up like wishing they've done it the other way around. That's my personal opinion about that. Janine is saying you're so right. Thank you. Let's keep on going. Sarah is asking, can we remove the lipedema and remove the skin in the same procedure, both together? We just answered that. Sarah saying thank you. You're welcome. Isma is saying, is there any non-surgery treatment for lipedema? Absolutely. There's stuff that can help with lipedema, and these are compression. Compression is key. Manual lymphatic drainage, MLD, anti-inflammatory diet. Like all these stuff, I think they're crucial. Before lipedema treatment and after your LippyLipo. They're like very important. The compression is important to minimize swelling, and the less swelling you have, the less fibrosis you're gonna get. And the less extravasation of fluid. Because what's lipedema? Lipedema, if you look at the word, lipid is fat, edema is fluid. So it's basically fat filled with fluid. And sometimes that fluid comes out, and then you go from stage 1 to stage 2 to stage 3, and ultimately stage 4, which is lipedema with lymphedema. So the end stage of lipedema, that compression, it compresses the lymphatics and it leads to lymphedema as well. So another reason why we want to treat it early on to prevent progression into late stages, because late stages are horrible stages. They're debilitating, people cannot walk, they end up with knee replacement, they can't play with their kids or grandkids. It's just like it affects their lifestyle, they cannot go on a hike, they cannot travel, they cannot just enjoy life, and then they hit that 60s, 70s, whatever, and then suddenly their quality of life, that's just, they're alive, but they cannot enjoy it. So you just don't want to get into that point. You want to treat it early on, get done with it, and so so you want to help it. So the help is definitely compression, definitely MLDs, kind of keep the stuff, get the flow outside through the lymphatics, and definitely ultimately LippyLipo is for sure. And it's a package of things. And even LippyLipo is not a cure. It's not like you being cured from lipedema. You would still need to continue to do the regular stuff to prevent further progression of the residual lipedema fat cells. So it's a lifestyle modification. It's not like having appendicitis, remove your appendix, you're done, you're cured. It's not the case. It's like the way lipedema is like somebody has diabetes, you can get it under control, lifestyle, this, that, but it's not like you do something and now it's gone from your body. That's not the case. So you gotta add all the stuff and do LippyLipo to get the best results possible. Okay. Sarah saying, do you do online consultation? Link is in bio. You send us the stuff, and all our consultations are online. Missy is asking, can you do upper and lower at the same time, or do you need to wait between the procedure? So do we do upper and lower at the same time? We don't. We stage them in separated by 1 day. So like our patient here, we did her lowers on Tuesday, and then we did the uppers or the thighs 360 on Thursday. And then we give 1 day in between, because I want because every time we do a case, we kind of like give as much numbing medicine as we can, and that is the limit, right? You don't want to go over the maximal dose of the numbing medicine that you can get. So you want to maximize every surgery. And I like to give it at least a day in between to let the body kind of absorb all that numbing medicine, digest it, get over it, catalyze it, and then we'll do the other on Thursday. Now the question is, to answer the question is, then why don't you just do the lowers and the uppers in one setting? The problem with that, if you do it in one setting, you're gonna have to cross the threshold of the maximal medication that you can give to numb that area. And that's, then you get into lidocaine toxicity, and that's very dangerous. So you wanna stage it. And that's kind of how we stage it. So we do lower on one session and then the upper on one session, and then we give 1 day in between for the body to catalyze all that numbing medicine, so we're able to maximize the session on Thursday as well. Again, we're being over cautious here. Could we do it 2 days like back to back? Probably we can, but if somebody for some reason have a slow metabolic or liver metabolism or that, just to be on the safe side for everyone, we give that 1 day in between. Harry is asking, now here is my land, is asking, would you come to London ever? Not to do surgeries. We get asked that. I was in Dubai a couple of weeks ago, and people were like, oh my God, inviting me to all those centers to do, because there's a huge need. There's a huge need in Europe, a huge need in Dubai and that Middle East and South America for lipedema. There aren't like, not many people are doing what we're doing here. Awake LippyLipo with these results, we're probably one of the few in the world who are doing that. So there's a huge need for that, and we get invited throughout. And the issue with that is I want to help as many people as possible. If I go to, let's say, to London to take a week or 2 weeks, so that means we have to shut down the practice here for 2 weeks to do that. And then you have the time delay and the time difference and to set up the infrastructure and that. We found there's so much time wasted to be able to set things outside than to have everything here in-house. So most of our patients fly to us. If they want like LippyLipo, high quality, how to outcome, consistent that, they just fly to us for that. So do I go to London? Yes, to see friends and family, but to operate, there's no plan of doing that. Okay, Cat Lady in 1975 is asking, can we lose weight with lipedema to get the surgery only by losing the regular fat? Then yes, absolutely. Like our patient here, she's GLP-1 agonist, lost 20 pounds. So that helped her, and that's kind of probably helped her from needing a third session. So on her, let's say when we did her lowers, we took 2.2 liters out. The uppers, we took 4 liters out. So potentially, she saved the session on the uppers here. And kind of like, so you want to lose as much fat as you want. Now that being said, I'm very careful because most lipedema patients have been abused. They're like, oh, you gotta lose fat, you gotta diet better and all that stuff. And it's all nonsense because lipedema is resistant to diet and exercise. And it's a vicious cycle. Because it's resistant to diet and exercise, it affects with patients' mentality. And then patients, they start doubting themselves and then thinking, maybe I am not doing the right thing, or maybe it's on me. And they go into that vicious cycle, which leads to stress, anxiety, and then potentially bad lifestyle habits. So we gotta be very careful about that. Tell patients lipedema, you're doing your best. It is what it is. This is where you are. Let's get you to where we need to get. And just kind of like, but if you're able to lose, if you have enough regular fat where you're able to lose it, because the real answer is you don't know. Is 80% of your fat lipedema fat and 20% is regular? You're not going to lose much by diet and exercise. But if your 20% of your fat is lipedema and 80% is regular fat, then yes, you're going to lose a lot with diet and exercise. So I'm very cautious when I tell people, oh, you got to diet. Everybody needs to have a healthy lifestyle and eat well. That's a no-brainer. But different people with lipedema their body would react differently to diet and exercise, just based on the ratios of lipedema fat to regular fat. If you have a high lipedema fat, low regular fat, diet and exercise is not going to help you much. Even GLP-1 agonist is not going to help you much. But if you have an inverse ratio, a little bit lipedema fat, a lot of regular fat, then diet and exercise will help you a lot, and GLP-1 agonists will help you a lot. WHOSIER, I filled out a form and sent in pics almost a year ago. Should I have heard back by now? You should. If you want to fill them again and then send them, and then we'll have Jerry take a look at them. Take a look. We usually, when patients send us the stuff, we usually get back to them within 2 to 3 days, 2 to 3 business days. We do get around like 400 inquiries a week, so we get a lot. And sometimes some of these they might not get us for some reason, or so we're always continuously moving, tightening our systems and processes, just trying to make sure like we are getting all these. So if you are in that category, send us your information again. We'll take a look at it and then we'll get back to you. We don't ignore anyone on purpose. So whether you're a candidate or you're not a candidate, we would reach out and would let you know kind of like, where you stand, all that stuff. Robin is asking, how common is lipedema? Short answer to the first answer is 11%. It's around 11% of women have lipedema. In my opinion, I think it's actually higher. The other day I was in the mall with my wife and daughter, and I was like, I had a piece of paper and I was like, you know what? I'm gonna actually count. So, and I would look at people, I was like that odd guy kind of looking at people, just kind of see, and I had a piece of paper, like I counted how many women they passed and how many of them I could see their ankle or kind of like type 3, just see if they had lipedema. And from the short thing that I did, I got like 16%. Now, I might be sitting in a mall who had a higher percentage of patients who had lipedema, but if you look at the literature, it's around 11% of women have lipedema. Probably it's underreported. More people probably have lipedema than not. A lot of underdiagnosed, because sometimes lipedema it stops at the knee here, and if lipedema stops at the knee, this is type 2 lipedema. It might not be diagnosed, so it doesn't mean the patient doesn't have lipedema. They have lipedema, but it's undiagnosed, because the most common teaching is, or kind of people kind of are used to lipedema having tree-trunk appearance, cut-off sign at the ankle, but not everybody has to have a cut-off sign at the ankle. If you have it, you're type 3, which is the most common type, but not everyone has it. So it's about 11%. The other question for Robin here is, I'm pretty sure I have it, but want one more child before I get the surgery. I don't think it makes sense to get the surgery then get pregnant again. Not sure I agree with you, Robin, here on this part. Is the problem is with pregnancy, it flares lipedema. So we know lipedema starts at puberty, gets worse with the pregnancy, and with every additional pregnancy it gets worse, and then menopause really makes it worse. So I tell patients, you're kind of like, in between, treated before, because if you go through pregnancy, now you might go through pregnancy and your lipedema might not get worse, might not progress to later stages. But there's a decent chance that your lipedema will progress to a deeper stages. So if it progresses to a deeper stages, now you have expansion of the skin. If you have expansion of the skin, you probably would cause you to need skin resection or thigh lift in the future. If you treat your lipedema earlier, before your pregnancy, then less chances of expansion and potentially less sessions to get you to where you need to get. So that's kind of how we look at it. Now, sometimes some people, they say, hey, you know what? I want to get my child next year. I want to be done with it and then do it. Then you want to take a risk. That's okay. But as long as you're making the decision, knowing all the information. My experience has been that you don't know what you don't know. And you don't want to make decisions based on things that you don't know. So if I'm able to get you all the information that you need to know, then make a decision based on that. And knowing that you're making decisions based on all the information that is available, it will allow you to make a better decision for you than not knowing a lot of other stuff. And one answer might be right for one patient and might be wrong for another patient. So different patients are different, and different life habits and lifestyle and kind of being in certain period of stages of their life might be different than somebody else. So it's a personal decision, but my job is to tell you kind of like what the progression of lipedema and what do we recommend from a medical standpoint. Rain is asking, do you recommend a certain amount of time between someone having LippyLipo and skin removal surgery? Great question. At least 1 year, because it does take 1 year for the skin to fully redrape, for the swelling to go down, to get you to the final outcome. Anything lower than that, there's no need, because let's kind of take an example here. Let's say you get the procedure done, you're like at 6 months, you're feeling good, still a little bit swollen, but you're like, I'm good, I'm gonna get thigh lift done. You get it done. The issue with that, let's say if you still have 20% residual swelling at 6 months, and you tighten the skin, but you still have 20% residual swelling, then when the swelling goes down a year or two later after the thigh lift, then you're gonna potentially need another skin resection. So you wanna wait at least a year until all the swelling is down, until all the skin is redraping, and then do a thigh lift is needed. Again, in our experience, most patients, they end up not doing a thigh lift or skin resection because they didn't need it, or they were okay with having a little bit of kind of like extra skin. Somebody who's like in their 60s, they're like stage 2, stage 3, having a little bit of laxity of their skin is not a big deal for them. What they're looking for is they want safety, they want consistency with their results, they want to be able to keep up with their significant other, they want to keep up with their kids, grandkids, their friends, they want to go out, they want to hike, they want to travel, they want to see the world, they want to enjoy life. That's where they're looking for. Somebody in their 20s, they're looking for different things. So again, what's a good answer for a certain patient may be a different answer for somebody else. And that's the beauty about what we do is everyone is different. Every procedure is different. Every lipedema fat is different. Sometimes within the same patient, one leg can be very different than the other leg. Certain area can be more fibrous and thick and dense compared to other areas. So we gotta be able to factor all that in there. And what I love about like awake is patients are awake, so we're able to talk about that during their procedure. Like, oh my God, like, and I'll be like, she'll be like, oh, and I'm like, the cannula is clogging a lot because we don't do manual extraction. Everything we kind of get out through the cannulas, and we use tiny cannulas. And when we do that, sometimes the lipedema fat is like so nodular and like thick and fibrous, it clogs the cannula. So then I'll ask the patient, I'm like, is this area usually tender for you? It's like, oh my God, that area, like if somebody's touching me on that area, it's so much pain. I'm like, okay, that explains, because now you have so much thick nodular lipedema fat cells that's causing that. So kind of like, that's kind of like the, that's kind of like, just seeing the patients and being, because they are able to connect the dots, and I'm able to kind of like also connect it on my end. Glow is asking, what are restrictions after the procedure? And what's the downtime? So immediately after the procedure, patients walk out, which has been a huge change for us with LippyLipo, because like you finish your case, like you look great, she's, put the compression on, she stands up, she puts her stuff, gets her water, and then she's walking out to the waiting room and to her car. So I'm like, that's awesome. So immediately after, patients are feeling great, they're still numb from the numbing, they're able to walk, no need for the wheelchair, stretcher, all that stuff. They can see the results. I usually airdrop the pictures, kind of the afters, and kind of like immediately on table the videos, pictures, whatever we take. So they're seeing that. It's just like they're into a high. They're like, oh my God, I'm done. It's done for the day. It's a long day for them because like the entire day we're doing that case, right? So you walk out, and then usually kind of the discomfort starts around 2 days, kind of where the numbing starts to go. What happens is the numbing starts to disappear in the first 2 days, and then swelling starts to kick in. Because immediately on table, there's no swelling, minimal, a little bit of fluid, right? But minimal swelling. So swelling starts to kick in, and then the numbing medication is going away. And that's kind of like, they hit that 2 days afterwards, and then kind of like it gets, it gets kind of, they start kind of like feeling it. And then it peaks. Some people, they peak at 1 week. Some people peak at 2 weeks. Some people peak at 3 weeks. Everybody after 3 weeks, they turn the corner. So I tell people 1 to 3 weeks your peak is gonna be. No one knows, depending on your body, the stages, the quality of your lipedema fat. So some people peak literally at like 4 or 5 days, 1 week, and then they turn and like, oh my God, that was easy, nothing. And some people, they really have a hard 3 weeks, kind of the other end of the spectrum, like a lot of bruising, a lot of swelling. They're taking pictures, sending it to us, like, oh, is this normal? Is this okay? Kind of like they're used to seeing me talk about that. They're not used to seeing kind of like on the other side. And then we'll be like, you belong to those 20% where you're gonna have it. You're gonna go through the first 3 weeks, and then you're gonna turn the corner. And then they turn the corner at 3 weeks, and then like at 1 month, 2 months, like, oh, it looks awesome, like. So we're kind of seen both spectrums. So we tell people 1 to 3 weeks. It depends where your body is gonna plateau. And once they turn the corner, they know it. They know that they turned the corner, because now the swelling is going down. Now they're feeling better. Now the bruising is going away. What I've noticed is what helps a lot is having a good MLD therapist, because a good MLD therapist helps milk the fluid out, minimize the amount of swelling that they have, so it helps in that process. And they have somebody to talk to, and somebody who has seen many of those, so they can support the patient in the post-operative period. So it helps not only physically, kind of like the actual, from a functional standpoint, it helps psychologically as well, because they've seen it, they've done it, and most of the times they're complimenting the patient, like, oh my God, like, they see many surgeons and many results, and then when they see our patients, they're blown away, and they send us like emails and stuff. They're like, oh my God, we're gonna send our patients to you now, and the ones that they need surgery just because of the results. So I've found good MLD helps them. But I've also seen some MLDs, especially if they're not experienced with lipedema, it makes it worse, because the MLD is now scared, like, oh my God, this is swollen, I don't know, is that a blood clot or not? Now the patient is like so worried, it's like, oh my God, and now they go into a bad cycle until they get to us, and then it's like, hey, it's okay. So then so you gotta make sure you go to somebody who is experienced with lipedema, who has done many MLDs on lipedema patients, and these are the ones you wanna go to for after your procedure. It helps significantly, and it helps you peak sooner. I found that without MLD, the peak is a little bit later, with MLD, a little bit sooner. Now, some of our patients are like type A personalities, they're the go-getters, they work non-stop, all that stuff, like, executive level patients, and they want to go back to work in like 5 days. And these are the patients that like, oh my God, it's just too much, and because that's their personality, they just want it to be done like yesterday. And you gotta give time for your body to go that. So I'm like, for those patients, if I sense that are the type, now in surgery, I tell them, hey, take time off, relax. Look at your life from a wider angle, and this is just 2 or 3 weeks of your life. Go somewhere on the beach, just sit, relax, have fun, take a long vacation, and then you have plenty of time to go back to work. So you gotta see what stage of life you are, what type of body you have, what stages, and kind of decide on that. Okay. In terms of downtime, what's the downtime? We speak about 1 to 3 weeks. So I'd say around those like few weeks after surgery. But you're not like sitting in bed doing nothing. You're just walking around. There's no drains. There's just kind of that. In terms of restrictions, I tell people like 4 to 6 weeks. Around 4 weeks you're able to go back to normal life. The main limitation, like early on, is you don't want to do something to raise your heart rate too much or your blood pressure too much, because that can lead into bruising and swelling and all that stuff. You just don't want to do kind of like that too early on. Brandy is saying, how do you make sure your patients don't have nodules or uneven skin post-procedure? Great question, Brandy. So when you look at table, you look like nice and smooth, and that's how it looks at about 1 year after the surgery. Now, even our patient here at 1 month, if she's doing MLD or at home, if she's feeling, she's gonna find or she's gonna feel some area that have nodules and have irregularities. And we call them knots. Sometimes these knots can be a muscle knot, kind of because of the stress of the procedure, or kind of like it's a new area. So you tell people just massage it. Massaging, if it's a muscle, it's gonna help, and sometimes the fat wants to come together and the fluid wants to come together, and same. So I tell people kind of like put your palm on it, kind of put that thinner eminence here on it, and just with a circular motion, just massage it. It really disperses the thing, that area. So it tells your body just don't come to that area, and you just kind of massage, circular motion, and the more you do it, you'll be surprised. And as soon as you feel those knots, that's when you start doing. And everybody's gonna have those knots. Whatever you feel, you put your hand and then you massage it. You see another one, you put your hand and then you massage it. And usually MLDs, good MLD therapists, that's what they do. As they are doing the milking, they get to an area they feel kind of that, and then whether it's a muscle knot or it's a fat knot, you just go in and you massage it so it disperses. Sometimes it can be fluid, and if it's fluid, you just milk it out or milk it back to the lymphatics. And these are very normal. Glow is asking, what's the likelihood of a return of lipedema fat? I'm sorry, I missed some. I'll go down to that. Okay, Louis is saying it's pity you so far. Thank you. But again, we're literally 1 hour north of Nashville Airport, so a lot of our patients fly to Nashville. They come here and come over there. That's the thing with lipedema. It's what we've done. It took me almost like 20 years to get to this level, and that's, I feel, where patients are coming from, or where you guys are coming from. It's it's a very steep learning curve for LippyLipo, and to get these results consistently all the time on patients with lipedema. So you're gonna find very few people who are able to do that in your area, and that's been the hard part for our patients. And I need to figure out a way like how to. That's a bigger question, like how to be able to make the procedure simpler and make it like so other physicians are able to do this quality work. Next question we have Glow Girl 2020 saying, what's the likelihood of a return of lipedema fat? Another way of asking this question is kind of what's the regrowth rate or recurrence of lipedema fat cells? It's very minimal. We don't see it very often. I'll say less than 1% if you're looking for a number. It's a very low chance, or less than 5% if you want to be safe. In our experience, we haven't seen it much. I think if you do LippyLipo, if you do great work, you get great results, you thin it as much as we can, and you're consistent with your healthy lifestyle, diet and exercise afterwards, the chances of regrowth is almost, it's less than 1%. It's very, very low. We haven't seen somebody where you've done this, you get them here, and then they come, like, say, 2 years later with stage 3 or stage 4. We just never seen it. It's 0%. Even low chances, like we just, it's very, very rare. But the key is to maintain consistency with your lifestyle afterwards. Louis is saying, can you reconstruct fat knees and make them look normal? And that's what we do. We take lipedema knees and kind of the shape of the lipedema knees and lipedema fat, and we kind of shape them to that. I think I have pictures of the back as well to see this is a back picture. You can see like how narrow the knees are here. If you look over here, Louis, you see kind of like normal. So if you look here, you see kind of like that knee. Look how much narrow that knee is. Very normal. Normal shaped knee. And that's the key. Normal shaped ankle. You see the Achilles tendon here. And that's the key with lipedema. You want to narrow as much as possible at the knee. Because goes down the thigh, you want to narrow at the knee, go down to the calf, and then narrow at the ankle, and then go down to the foot. And these two, the two most narrow points should be the knee and the ankle. And that's what gives the visual normal shape of the lower extremity. The problem with lipedema, the knees are pretty much the same width of the entire leg, so it looks like a tree. But the good LippyLipo is the one that's able to really, like, you want to narrow down so that you have like skin, muscle, bone, kind of like almost in that plane, and then go down to get the best, these amazing results. And for these, like, we spend like so much time doing that in surgery with multiple cannulas, micro cannulas, all that stuff to get it here. Louis saying, if I may ask, where are you based? I am from South Africa. That's awesome. Within the US, with an hour north of Nashville Airport. I haven't been to South Africa. I'd love to go on vacation. But I hear it's awesome. Zena saying, I'm Zena from San Diego. Thank you for joining us. I know that's Jan is saying, can I have this procedure in my 60s? I am 62 and I did this procedure. Actually, that's great. The answer is yes, and this is your window. We do, actually, tomorrow's patient, I think she's 61. I have to double check, but I think she's in her 60s. And I tell patients, in that 60s, you have a window. Because 60s, usually patients are relatively healthy, that kind of that into that, and usually they're like stage 2, 3, kind of getting to that point, because after menopause, we know lipedema gets worse with menopause. So I'm like treated, because if they don't, let's say if they're stage 2, 3, they advance to 4, lifestyle is bad, or if they get any healthcare issues, health problems, then it prevents them from getting lipedema procedure done. So take advantage of that window, get it done, and then live the rest of your life in a better position. Most of these patients in their 60s are like, they're so tired of lipedema because they lived with it since puberty, and they never knew that that's what they had, and they were like kind of mentally abused throughout their life. And so these are one of our happiest patients, because so much trauma, so much stress their entire life, and now they have the solution. So yeah, the short answer is yes, do it. Handy saying, thank you for your time. You're welcome. I love doing this. So I want to thank you guys in return. I'm sorry I don't have my normal energy here. I don't know I haven't been feeling well for the past 2 weeks. So, but I'm feeling much better than before. So I love it. Adio is saying, how long is the wait for surgery once one decides to go forth? I'll have you check with Jerry on those, kind of once we send, kind of have you take a look, and then depends. It depends if you need 1 session or 2 sessions, and Jerry has been very kind of like, she works around the schedule and all that stuff. Politico is saying, does this procedure impact lymphedema too? Absolutely. So stage 4 lipedema is lipedema with lymphedema. Stage 2 lipedema is just lipedema. Stage 3 lipedema. So 1, 2, 3 is just lipedema. Stage 4, you add lymphedema to it. Why is that? Because if nothing is done for lipedema, with time, it creates fibrosis of the swelling. It pushes on the lymphatics, and now the flow from the foot through the lymphatics back to the heart and the lymphatics is obstructed. So the fluid gets outside the lymphatics, and now patients have lymphedema. So lipedema causes lymphedema at later stages. So you potentially prevent the formation of lymphedema when you treat your lipedema early on. So definitely, early treatment is key, guys. It's very, very important. Farah is saying, how do you know if lymphedema or fat? If you go to our live Q&A about lipedema and watch those, you will be able to know exactly if you have it or not, what type you have, what stage you have. But it's like a thin rule is lipedema is easy bruising, swelling, pain, runs in families, resistant to diet and exercise. If you look at the shape of the leg, runs in families, both legs are involved, that's lipedema. One leg that's like that and the other leg is normal, it's more likely to be lymphedema. So if you look at those, you'll be able to tell significantly kind of like what you have. HDN, HND 99 saying great explanations, thank you, you're welcome. Brown is saying my dermatologist wants to send me to general surgery for my lipedema fat. That won't help me, will it? It depends. General surgery, I would just, the thing is with lipedema is you want to go with a real specialist. Well, first, I'm happy that your dermatologist at least knows that you have lipedema. Unfortunately, most people don't know. So at least they're one level higher than your typical dermatologist. But for who do you go to, make sure you do your homework and make sure that person does lipedema, they do high volume lipedema, look at the before and afters. How many do they have? How many have they done? Are the results you're looking for? The day where your procedure is being done, how many other surgeries that surgeon has? And this is very important. Talk to other lipedema patients who had that procedure done through that surgeon. Are they happy or not? See their results. Do your homework, it's very important. The issue is, if you do it and you don't get consistent results, it's very hard to correct those. It's extremely hard. Especially if it's overdone or over resected or over liposuction. It's almost impossible. It looks like skin graft appearance. Under resection is actually better, or under liposuction to me is better. I can fix those because it's like really shaping. It's much easier to take more and shape better, right? That issue was that they undershaped. But if they overshaped, it's very hard to put back on and then fix it, and doing fat transfers and all that makes it much harder. So I'm glad that your dermatologist was able to understand that you have an issue and it is lipedema, and probably that's all what they know of a person who does that. But I think it's on you now to do your homework and match with a surgeon. That's what they do, and ask those questions and look at that and kind of look at that history, and ideally you'd find somebody like us, like what we do, and we took it to the extreme, right? Like most practices are not going to be like that, so I don't think you're not going to find somebody like us. But if you can find as close to us as possible, like we do one procedure per day, that's it, you're the only case that day. That tells you all the attention, all the energy is going to go to you. No one's going to get any other attention. So you're going to have the best result or experience possible. If that's all what they do in their practice, it's not like they do this and that and the other thing and Botox and fillers and breast augmentation and tummy tucks and whatever. That's all what they do. They just do LippyLipo, lipedema liposuction. That's all what that acts. That adds value because everything is evolved around that. Seeing that before and afters, like all these questions and that, if you do your homework and you put them like as a list, you're gonna make 80% better decisions than not doing those. Feda saying, where are you located? Basa saying, come to Istanbul. Thank you. I've been there once. It's beautiful. Not to work, I only do procedures here, but I took my wife and daughter there once. Fela saying, where are you located? We're 1 hour north of Nashville Airport in Bowling Green, Kentucky. Zina saying, I had lymphedema in my left lower limb. Okay, and I had a lot of surgeries, but I think I got it in the right one now. Can I do liposuction for it, or danger me some of lymph nodes will be sucked that too? That's an amazing question. For somebody who had lymphedema bypass surgery, you gotta be careful, because if you do liposuction in that same area, the connection, or what we call anastomosis in the medical world, where they connect basically your lymphatics to the vein, And if you go through that anastomosis with the cannula, you can disrupt it, and then you end up having lymphedema again. So the best person to do your liposuction procedure probably is your lymphedema surgeon, because he knows exactly where those anastomoses were done, and hopefully he would have those marked, so he knows not to go around them, so it doesn't disrupt that. It's a very good question. 1975 saying, thank you so much for your honesty. I appreciate it. Thank you for being here. Politico is saying, will the procedure make lymphedema worse? Good question. In the right hands, it shouldn't. The problem is people ask about, basically the question here, lymphatic injury to the lymphatics during liposuction for lipedema. So the lymphatics, let's say this is the skin, this is your lipedema fat, regular fat, and this is the muscle here. Lymphatics that actually sit very deep, kind of around the muscle area, and then kind of. Now, if you do good tumescent, good fluid injection, and you know what you're doing, and you're using the right cannula, and you're using that technique, we personally haven't seen any lymphatic damages, nothing. But we've seen somebody with lymphatic damage after doing it with somebody who's not experienced with that. And the problem, what happens with those, and that's where you see also fat embolisms and kind of other problems, is when that plane is being violated, when the plane where the muscle is and the fascia that covers the muscle goes through that or deeper to that, that's when problems happen. Another reason why awake is the way to go, because if you hit that plane, the patient's gonna feel it, you're gonna know it as a surgeon. If somebody under general anesthesia, they cannot feel that. So that's where higher risk of complications with that. So if you do that tumescent technique, you know where you are, you're using the curved cannulas, you're doing micro, all that stuff, then you just very, very limited chance of having lymphatic getting worse. If anything, it prevents future progression from lipedema to lymphedema. Missy is saying, is that an estimated cost for the procedure? Does it depend on each case? Different patients are different. If you go on our link in bio, kind of submit your information, and Jerry will get back to you here. If Effie is saying, should I lose weight first and then do LippyLipo, or do the surgery first and then continue to lose weight? That's a great question. If you can lose weight, if you're actively losing weight, that's great. Do your consultation, do that. So by the time you plateau, you'll be ready for that. But most lipedema patients are not able to do that. They're kind of they are at a plateau, and that's kind of that because lipedema fat is resistant to diet and exercise. So if you lose weight, you're not losing your lipedema fat, you're losing your regular fat. So, but that helps you with the amount of sessions you're gonna need, and you're gonna maintain that healthy lifestyle for afterwards. So the short answer is, if you're actively losing, continue to do that. Of course, that's amazing. But most lipedema patients actually don't fit that category. That actually their entire life they're battling weight because of their lipedema fat cells, and they're not able to get rid of the fat cells because they are resistant to diet and exercise. Robin's saying, thank you so much for answering. You're welcome. Heidi is saying, it's the hips, it's the bum, hips, and additional surgery. So the way our patient here, we did 360 from here down and then 360 from here up. And when we do the thighs, we always leave the saddlebag area. Now, the upper buttock and kind of like the love handle area is usually done with a 360 lipo to the trunk. So that's a different procedure. But saddlebags down to knees is one. We call that 360 thighs. From the knees down to the ankle, we call that 360 lower legs, or 360 knees, calves, and ankles. Rain is saying, perfect, thank you for all the information. I'm down more than 200 pounds and trying to ensure I take the right approach. That's amazing. Congratulations. Very, very hard for lipedema patients to lose that much. And the fact you've done that, that speaks volume. So that's perfect. Keep on losing rain until you hit your plateau, kind of where you need to do. And then you do your LippyLipo procedure, and then you do skin resection if you want to go down skin resection route. Kind of to circle back to when we were talking about skin resection and lipedema, all treatment, always do your LippyLipo first, your lipedema treatment first, wait a year, and then do your skin tightening. Just because by losing 200 pounds, I already can tell you're gonna have a lot of extra skin. That's okay. I mean, that's part of the journey, but that's awesome. That's amazing. Congratulations. Zina is saying, I have lymphedema since I was a teen in my left lower limb. I think I have it in the right one. Do you recommend liposuction for the right, or my lymph nodes will be sucked too? I need to take a look at your legs and kind of your chart and see the causes of lymphedema. What we do here is more lipedema. We treat lipedema, not lymphedema. Lymphedema, it's a totally different disease and entity. The main, that being said, so I add value to you here. The main treatment for lymphedema, though, there's like two arms to it. One is liposuction. Liposuction can help lymphedema. But truly, the true cure or the true treatment for it is bypasses. Is lymphatico-venous bypass, where they take the lymphatics and then they hook it up, the lymphatic vessel, and then they hook it up to a vein. And this way, the lymph comes to the lymphatics, it goes to the vein, and then the vein takes it back to the heart, and then it pumps it. And this is kind of really the main treatment. And one of the questions was, can you do liposuction after having that done? You can, as long as you go to a surgeon, ideally your surgeon who's done the bypass originally. They know where they put those anastomosis, where they hook the vessels together. Because the last thing you want to do is you want to damage those vessels, because now you take yourself treating lipedema and causing lymphedema again. So you gotta be, it's a tricky situation, and that's different level of kind of like what you have and what we're talking here. Basak is saying, if I decide for the operation, how many days I have to stay in Nashville? So basically, like, patients usually fly in on Monday, they get their procedure on Tuesday, and if their blood work is high enough, then we do 2 sessions for them. We do one on Tuesday, one on Thursday, and then they fly back out on Saturday, usually. And Jerry can help you more with that in terms of when to stay, the airport, this, accommodation, because most of our patients, more than 90% of our patients are out of state. They fly to here, they get their surgery, and then they fly back. So we're kind of used to that. Carolina is asking, what type of compression garment is used for post-op care? There's so many companies out there. The key with compression is you want to make sure you want to have 20 to 30 millimeter of mercury pressure. Lower than that, I think it's too low to have enough compression. The other thing that's important is you want to make sure the compression is smooth. You don't want to have seams on the inside or something that can leave an indentation. You want to have, like, on the inside, you got to make sure there's no seams. And from listening to all patients, you want to have something that have a crotch. So if you want to go to the bathroom, because after the procedure, we'll have patients use that compression, not take it off for at least 5 days. Because it keeps everything compressed, they don't get dizzy when they take it out, and it's very hard to put it back in. So they shower, they do all the stuff that they want to do with the compression on. So you gotta make sure it has an opening so you can use the bathroom. Brandy is asking, how soon post-procedure should someone get an MLD? Usually around 1 week. The sooner you start, the better. That being said, we have the compression for about 5 days. So I'd say about that 1 week mark, we'll have patients to start doing the MLD on their legs. At the end of the procedure here is we milk the fluid. It's not like an official MLD, but we milk the stuff so we get rid of as much of that fluid as possible. But you want to start your MLD a week after the procedure, and if you can get it twice a week, that would be ideal. So twice a week until most of that fluid is gone. Lena is asking, is there an ideal body weight to be able to have this? Not really, some people ask about, hey, do you have a BMI restriction or this, or do I need that certain weight? And because they've probably had discussions with other plastic surgeons or other physicians, and some people say, oh, above this BMI, or they talk to a friend, and what we do is very different. It's LippyLipo, it's fully awake, so there's no criteria. Well, and most of patients, they use 35, because anything above 35 BMI, if somebody is going to sleep, the risk of complication goes up, from anesthesia, from positioning, from brachial plexus injury, nerve injury, all that stuff, it goes higher. So the medical literature, they want safety, which is, and they should, just to keep everything kind of safe. So they try to limit to 35. But when you're awake, you're not gonna lay down if your shoulder is hurting or if your nerve is pinching. You're gonna move, so that it's like being at home, like relaxing on a couch or on a bed. So we really don't have a BMI requirement. We used to have many years ago when we were doing these cases under general anesthesia, but not at this point. Yes, he is saying, I have a lot of scar tissue from a previous liposuction, not 360 lipo. Can you fix the appearance of it? And I guess that's what we were talking about when over resection. Probably that's kind of what you mean by scar tissue. A lot over resection or over liposuction or over suctioning can lead to scar tissue, because you need to have a thin layer between the skin, fat between the skin and the muscle. Because if you think about, if you take out all the fat, what you're left is skin and muscle. What's skin and muscle? It's a skin graft, so it looks horrible. It's a lot of scarring, fibrosis, nodularities. It doesn't have a good cosmetic appearance, and that's the problem of that learning curve. It's very hard to get these results, because the learning curve is very steep, and to get there, people have to go through a lot of trial and error to get to that point. So you gotta do your homework. To answer your question here, so I'm adding value to you, is I wish that question was like, they have done it and now I still have some. I'd be like, we probably can improve it and make it better. With over resection, you're talking into fat transfer, fat equalization, and so many procedures. And most of these cases, you really cannot improve much. Now, without pictures and stuff, I cannot tell, but most of the times, with over resection, we tell patients, because the last thing I want to do is operate on somebody and knowing they're not going to get the results they want. I would never do that. So most of these patients end up being not candidates for procedure with us, because we cannot get them to where we need to get. We cannot look at these results. That's kind of again, I'll have to see if that can be improved or not, but most of these cases are usually very hard to correct. And then I was saying, would you recommend someone does this before skin removal surgery after extreme weight loss? Absolutely. Actually, you want to do this first and then skin removal, so you get the best outcome possible. George is saying greetings, hello. Sally is saying, do you recommend someone get surgery before or after pregnancy, since hormonal changes can accelerate this condition? Great question. So we talked a little bit briefly about that earlier on. Do it before. If you can do it before, because we know lipedema starts at puberty. It gets worse with pregnancy. With each pregnancy, lipedema gets worse. So if you can treat it before you have those hormonal changes, so you're keeping it at bay. Because when lipedema advances in stages, now you potentially need higher chances of skin resection, ultimately, after a year of your LippyLipo, and potentially you'd end up needing more sessions. So you want to keep it at bay, you want to treat it early in the procedure. Island 305 saying, how much is the procedure? Go to the link in bio, send us your info, and Jada will get back to you with that. And Jen saying, thank you for all what you do. I'll get my information to move forward. Glorex saying, can the insurance cover this health? I'm going to try to call it. I have a patient to see, but we go live almost every Monday at 12, unless if we're doing a case, then I won't. But I'd say most of the Mondays we're going live. So if I didn't get to your question here, and then there's tons of questions, I'm not gonna be able to go through them. Yeah, sorry guys. Okay. Every Monday, 12 p.m. Central Time, we go live, answer as many questions as we can. And if you have like any other questions, send it to Instagram. I write them down so that we can like go over them as well, and join me and ask me your questions and answer them. Again, I apologize for like losing my voice and kind of that. For some reason, I don't know why, like the past 2 weeks, I feel better now, but whatever, it is what it is. Anyhow, I'm excited. I'm gonna see our patient here. Love you guys. Thank you for joining.